Hi, and welcome back to the Pro PA podcast. I'm Angie Urbina, your host for the dermatology section of this series, where we tackle clinical medicine briefs in dermatology. Over the coming episodes, we'll continue diving into high-yield topics straight from the PANCE blueprint. Today, we're diving into rosacea, a chronic dermatologic condition that often gets confused with acne vulgaris. Whether you're preparing for the PANCE, managing patients in clinic, or a medical enthusiast, this episode will provide the practical pearls you need. Let's get started. Starting off with the pathophysiology. What is rosacea? Rosacea is a chronic inflammatory condition of the pilosebaceous units coupled with an increased reactivity of capillaries leading to flushing and telangiectasias. Unlike acne vulgaris, comedones are absent in rosacea. The pathogenesis of rosacea is poorly understood. However, factors such as abnormalities in the innate immune system, inflammatory reactions to cutaneous microorganisms, UV radiation exposure, vascular hyperreactivity, and genetics have been identified as potential contributing factors. So, who does rosacea affect? Most commonly, this will be women aged 30 to 50 years old, but make note that rhinophyma is more common in males. Common triggers of rosacea include alcohol, spicy foods, hot beverages, extremes of temperature such as hot and cold, emotional stress and exercise, and also certain medications or hormonal changes like menopausal hot flashes. Here's a quick and easy mnemonic to help you remember these triggers. It is HATS, H-A-T-S. H is for hot drinks or hot weather, A for alcohol, T for temperature extremes, and S for stress or spicy foods. Let's move on to the clinical presentation. The hallmark findings of rosacea are facial flushing, which may be transient or persistent, telangiectasias, which are enlarged cutaneous blood vessels, and erythematous papules and pustules that usually present on the central part of the face, so being the cheeks, the nose, and the forehead. In severe cases, phymatous changes due to sebaceous hyperplasia, edema, and fibrosis may present, and this will appear as thickened skin with irregular contours. And when present on the nose, this may be described as a bulbous nose. Some patients may also report ocular involvement, such as gritty, dry eyes, or conjunctivitis. Now, this is very important, and these patients will need to be referred to an ophthalmologist. The workup of rosacea is pretty straightforward. Diagnosis is clinical and based on history and physical exam. No specific laboratory or imaging tests are required unless considering something that mimics rosacea, maybe something like lupus, that also presents on the malar aspect of the face, would warrant some laboratory testing. Next, let's talk about the management. So first, some general recommendations. Number 1, sun protection. So patients need to be using sunscreen. This is crucial. Secondly is avoidance of the triggers. Patients need to understand that these triggers may cause their flushing. And now, as far as medication treatment, so let's break down rosacea into mild to moderate, and then secondly, into moderate to severe. Now, before I do, I want you to notice that the treatment resembles that of acne vulgaris. So you are going to notice the topical medications as well as the oral medications. Now, mild to moderate rosacea, which would be papules and pustules, this would be where topical therapies are used. So usually metronidazole is the go-to, but there are other options such as azelaic acid and ivermectin cream. Now, when treating a patient with moderate to severe rosacea, this being numerous papules and pustules, or in the case of milder disease that fails to improve with the topicals, this is where oral antibiotics such as doxycycline or minocycline are used. In cases that are refractory to treatment or you are seeing phymatous changes, oral isotretinoin is going to be the treatment of choice. Lastly, for patients who just have flushing and telangiectasias, topical bromonidine, which is a vasoconstrictor, can be prescribed. Another option for this would be laser or intense pulse light therapy. As far as prevention of rosacea, we've kind of already touched on this, but basically, daily sunscreen is non-negotiable. And then, of course, counsel the patients on lifestyle modifications, so avoidance of those hot drinks, hot weather, alcohol, extremes of temperature, and stress and spicy foods. Some patients may benefit from recommendation of keeping a diary so they can keep track of the triggers. Complications to watch for in patients with rosacea would be one, psychosocial impact. So you want to look out for low self-esteem and social anxiety due to visible facial changes. Also, you want to look out for those phymatous changes because these can cause permanent disfigurement. And thirdly, ocular involvement is very important. This can lead to chronic eye symptoms, so these patients really need a referral to ophthalmology. Now let's talk book med versus street med. As far as book med, this is usually to follow the stepwise treatment protocols with topical agents first. But sometimes what's seen in street med is to combine treatments such as a topical and an oral earlier for faster results, especially when it comes to moderate to severe cases. Now, before jumping into some clinical questions, here is a quick pearl. Remember that acne vulgaris has comedones. Rosacea does not. So that's a quick key to differentiate between acne vulgaris and rosacea. So let's go over 2 clinical questions to test our knowledge. Question 1. A 45-year-old woman presents with persistent facial flushing, telangiectasias, and small erythematous papules on her cheeks. Physical exam does not reveal comedones. What is the most appropriate initial treatment? A. Topical metronidazole. B. Oral isotretinoin. C. Topical benzoyl peroxide. Or D. Oral doxycycline. I'll give you a couple of seconds. If you chose A, topical metronidazole, you are correct. This patient is presenting with mild to moderate rosacea. Therefore, the treatment of choice is topical metronidazole. Question 2. A 55-year-old man presents with a bulbous nose and thickened facial skin associated with erythema and papules. What is the best next step in management? A. Topical metronidazole. B. Oral doxycycline. C. Topical bromonidine. Or D. Oral isotretinoin. If you chose D. Oral isotretinoin, you are correct. So in this case, this patient is having those phymatous changes. So we are seeing a bulbous nose and thickened facial skin. Therefore, oral isotretinoin is the treatment of choice. Great job on these questions, and thank you for tuning into the Pro PA podcast. Be sure to hit the subscribe button and turn on notifications to catch future episodes in our dermatology series. We'll continue exploring high-yield topics to help you dominate the PANCE and excel in clinic. And remember, this is the Pro PA podcast, where future pros in medicine are made. I'll see you in the next episode.